And just a reminder, we welcome everyone, and just a reminder that this is being recorded, and being present states that you are agreeing to be recorded. And Kim, will we be able to share it afterwards with folks?
We're going to post this to our website, so it will be available. Yes.
And we'll be able to share the PowerPoint with folks who attend as well.
Absolutely. All right. Well, we are going to go ahead then and get started. And thank you, Dr. Gibson, for talking about this webinar is recorded. I'm going to introduce myself because I may not know some of you on there. I'm Kim Schuler, and I'm the CEO for the Arkansas Behavioral Health Integration Network, or ABIN. And we are providing today's training as part of our opioid use disorder grant. And we want to thank HRSA for the funds to be able to provide this training and this opportunity. Dr. Gibson is co-presenting with me today. And Dr. Gibson is a psychiatrist who is also an addiction medicine specialist and board certified in anesthesiology. And she has been working with us as our subject matter expert on this grant, and has years and years of experience in this field, and is also a national expert in the field of integrated behavioral health. So I'm so excited to have her with me today. All right, so now we're going to talk to you a little bit about SBIRT and what is SBIRT, and what's the importance of SBIRT, how we can utilize this in primary care. Next slide. We do not have any conflict of interest. We are not being or anything to disclose. As we said, this project is funded by HRSA and the Rural Opioid Grant. Next slide. Here's our learning objectives for today. Today we're going to identify what is SBIRT and the key components of SBIRT. We're also going to talk about screening tools and identify some of the screening tools. We're going to talk about the importance of brief interventions, and then we're going to talk about some strategies to refer patients to treatment when it's appropriate. We're going to start with a brief video, and this video is a wonderful testimonial of patients who have been struggling with substance use and the importance of the SBIRT program.
I started using when I was 36 years old. I started with pot, and I was making a lot of money at that point, so I started using cocaine after that, and then I went to methamphetamines.
When you organize your day for purposes of drinking and the highlight is being able to finish your work, hustle off to a bar, hope to be there by noontime, take advantage of happy hours, buy in advance, there are bound to be consequences.
I was having a lot of dental work done, and I was prescribed Vicodin, and my dentist seemed to just give it to me all the time, anytime I needed it, and I became dependent on it. I had a habit and could no longer find Vicodin, and I started smoking heroin.
I was a teacher. Towards the end of my drinking, I actually drank before classes, in between classes, after classes, on the way home, and then to oblivion.
I didn't really recognize it as being a problem despite the 2 DUIs, despite the interactions with my wife where I would promise to quit drinking and then not and get caught.
I chose an individual to be in my life who physically abused me, and so I went to the doctor. I went to the doctor several times. I don't recall ever being asked anything about my addiction.
The physicians I saw didn't ask anything about substance abuse. They didn't ask me how much did you drink. They asked me things like, are you depressed? Are you nervous?
Well, in fact, it was never a subject that came up because the doctor had no idea that I was drinking and never assumed that I was. So yes, I think it would have been helpful to have been approached.
One of the things that helped me was having a screening form where I could write it down, where I didn't have to say it eye to eye. And then the doctor could read it and then bring it up to me.
Is it appropriate for the doctor to, based on my answers to a questionnaire, recommend or, give his analysis or his opinion of where I fall? Yeah, I do think it's appropriate.
I would fill it out, and I think I would fill it out honestly. A form like that has a certain anonymity to it.
Whether the patient takes that with him or her and thinks about it, that's a step in the right direction. Or if there is a dialogue that ensues between patient and physician.
I think that it would be worth the time to refer them to someone or provide them with a resource list. Whether they're willing to take the list at that time or not, there might be another time when they are more willing.
DUIs required treatment, but I didn't benefit from the required treatment at all. The only time I've truly benefited is when I chose the treatment or chose to accept the treatment. And the benefits of that have been very high.
Maybe the doctors could help by only prescribing narcotics for a certain length of time. I've gotten kidney stones, which are very, very painful. And I've never been given more than 10 pills at a time. And there's really not an opportunity for me to abuse that or to become addicted with 10 pills.
I was on stimulant medication for ADD. I was taking Adderall. And I found myself with two sources for my ADD meds. I took advantage of that. I doubled up on my ADD meds. And then I got caught by the pharmacy. I almost lost something that was really, really precious to me, which was my relationship with my doctor here.
When I relapsed, I felt I had actually failed my doctor, and I told her I felt I had failed her. And the response that I got was that I had not failed her, that I had relapsed, and that relapse is common, and that now you need to assess where you are, you need to assess why you relapsed, and we need to put together a plan to avoid a relapse in the future if you want to move forward.
Being able to have a doctor that I can be honest with and truthful to at all times has been a blessing. It's made it much easier to stay clean and sober.
Today, of course, I'm in the care of a physician who knows a great deal about substance abuse, and every time she sees me, she congratulates me on my continued sobriety, and it's her enthusiasm that makes me look forward to any office visit that I have with her.
It can make a big difference. It's made a huge difference for me in the last 7 years.
Most addicted persons want to be healthier and happier.
My main take-home message to doctors would be, don't be afraid to ask. It might help save a person's life.
We're starting with that video because, as you could see, the patient's relationship with the doctor is very important to the patients. And one of the things that the patients are also doing is they're saying, we want to be asked. We need to be asked. Primary care is the place that we could start identifying if someone does have risky use of some type of substance. So with that, we wanted to move into a poll, and Jenny's going to put a poll in for you. And if you could just please take a moment and answer these two questions, and then we'll talk about the results. And the first question is, does your clinic use Espert? And so you can choose the best answer.
Did the poll pop up in the chat?
Yes.
Awesome. Thank you.
Are you able to choose an answer?
Oh,
I see them coming in.
yeah, 3 people.
And I can't see the results.
I think I'll be able to share the results. So we still have 3 out of 11. Just tell me when y'all like me to share it.
Sure. So please take a moment. Don't be shy and answer the poll questions. We'll give you all another 30 seconds to respond.
And it is anonymous.
Yes, we can't see anyone's response. All right, Jenny, if you want to go ahead and close the poll, you could show us the results.
Did that come through? The results?
Yes.
Awesome.
So we have had 3 responses, and we have 67%, 2 out of 3 say, yes, we have a process to systematically screen all of our patients. And some, we don't use alcohol or drug screens. And then question 2 is we don't have time. Am I seeing that correctly? Not enough time for these types of screenings. So
They all answered other about why they are screening or not screening.
okay. Thank you. Well, thank you for taking a moment and answering that, because, you know, I think it's important for us to look at, are we screening? And if not, what are some of the reasons that we're not screening, and or how do we screen, and how could we enhance that process? So we're going to take a few minutes, and now we're going to talk about what is Espert. I know that I hear a lot about, yeah, we're doing the Espert. And I thought, okay, when I first started hearing about Espert, is this a specific type of screener? But actually, it has a few components. And so with Espert, screening is the first piece of this. And then based on the results of that screening, we look at a brief intervention and then a referral to treatment. So throughout the remainder of this presentation, we're really going to talk about the process of screening. How do we screen? What types of screeners are we using? Brief interventions. What do brief interventions look like? And then referral to treatment. What types of treatment options are available? Next slide. I also did want to say this is an evidence-based practice and it is endorsed by SAMHSA and HRSA. So now we're going to talk a little bit about background and why we should be screening for substance use disorder. We know that more than 40 million Americans live with a substance use disorder. However, fewer than 3 million are receiving treatment and specialty services. And so I think that's critical when we think about 40 million have been identified as living with a substance use disorder, but such a few number of people are actually receiving treatment in specialty settings. We know primary care is increasingly likely to fill the gaps. And as we heard from the patients in the testimonial, patients are coming to primary care and they're struggling with substance use. And primary care is an essential place for us to start to identify through screening when someone is struggling with a substance use. Next slide. So, one of the ways that we provide brief interventions with SBIRT is through motivational interviewing. And so we talked about screening, and screening is essential. You'll hear a lot of talk out there about universal screening. And when should SBIRTs be done? And so a lot of times we hear from practices that we're working with, oftentimes screening is happening at the annual wellness visit. But just want to encourage us to think about universal screening. I went to the eye doctor a couple of weeks ago for my annual exam, and I was surprised when they handed me a iPad, and on the iPad there are questions about how many drinks did I have and what period of time. And so they're screening me for substances. And of course, in the work that we're doing and preparing for this presentation, I was really excited and impressed that even my eye doctor was starting to use standardized screeners and use them on an iPad. Brief intervention, as we talked about, we will be talking about brief motivational interviewing strategies, and really how can we raise awareness? The research tells us if we can raise awareness with our patients, it's possible that we can move the needle on risky drinking or hazardous drinking and help patients decrease the amount that they're drinking. And then, of course, referral to treatment is referring to specialty care for patients with substance use disorder. Next slide. So what are the goals of SBIRT? So one, we want to increase access to care. We know that patients who are struggling with substance use disorder may be really struggling with finding access to services out there. We have a continuum of care, and we want to look at if we've identified through a screener, how can we provide more services on intervention and treatment. And we also want to improve linkages. So sometimes we know in healthcare that there's not a lot of communication sometimes from primary care to the drug and alcohol treatment services. And so we want to definitely work on improving that and really identifying what are some resources out in our community and how do we connect to those services. Next slide.
Yes, I wanted to share this about the Colorado SIM project. The Colorado SIM project was a statewide project from 2015 to 2019, where they got $65 million from the federal government to improve whole health care around the state. And so they had several different parts to this. And one of them was increasing screening in their primary care clinics. So one of the things they looked at, they did a survey of 415 practices to see why they may not be utilizing SBIRT in their primary care and non-mental health practices. And the reasons, the themes that they found was people didn't want to do SBIRT screening because they didn't have access to behavioral health services or providers for referrals if they've had positive screens. They found logistical issues related to the workflow in the practice. And they had some poor integration with the electronic medical records, getting the results from the screens, and then also to any referral partners. And another one had to do with concerns about patients having a negative reaction, thinking that patients would be offended. And so they didn't want to ask patients these questions. They were afraid that it would offend their patients and they wouldn't want to continue coming to that practice. And the other thing is there was an impression that patients were not motivated to address alcohol or drug use. Next slide. And if you think about the video, the specific video was asking those patients, what did they think about their PCPs, asking them screening questions. And you could hear all of them were, yes, they thought it was appropriate and that it was helpful. And just wanted to share that there's been several research studies done about patient attitudes about being asked these questions in primary care. Sometimes I think us as healthcare providers are more concerned about the stigma than patients are. And clearly, the conclusion of these is that patients are in favor of being screened. And they do also like the self-report measures, and especially being able to fill out a questionnaire first. They may be more likely to answer it because it feels like anonymity of answering a question. Next slide. So why do we do SBIRT? Kim mentioned some of this, and you can see the statistics, the consequences of substance use, and not just substance dependence, but substance misuse. We're hearing a lot about the overdoses and the effects from over drinking, and then including in this is tobacco and vaping products. Next slide. Alcohol and drug-related problems from drugs and alcohol. You know, in our primary care clinics and in our transformation programs and quality programs, we're very focused on diabetes, hypertension, statin use, and also trying to help patients stay out of the hospital to keep them well and provide some prevention. And oftentimes we're very focused on these diseases, but we're not looking upstream at some significant problems. Alcohol and drugs may be contributing to making these diseases worse. So it's important that we screen for alcohol and other drugs and tobacco, as well as some of the other chronic disease work that we're being done. Next slide. And this slide also goes into some of the other consequences, including cancer, kidney disease, causing accidents. There's a lot of liver disease. I know back in the 80s when I was in med school, we had never heard of cirrhosis from diabetes. It was only related to alcohol. And now that we're seeing that alcohol and diabetes can cause liver cirrhosis, so you've got to address both. And so it's important to find a way to do screening for the alcohol and drug use, as well as doing A1Cs and looking for diabetes otherwise. Next screen. So how effective is SBIRT? You know, the USP-STF recommendations are that we do SBIRT screening in addition to depression screening for tobacco. And you can see that the screening and brief interventions and referral to treatment for alcohol and misuse are definitely evidence-based. There is evidence for screening for drug misuse and abuse, as well as referral to treatment. The brief interventions, if someone has drug dependence, have not been shown to be evidence-based brief intervention, but it has been shown to be effective to use motivational interviewing and assessments with alcohol, drugs, and tobacco in terms of helping people identify what their own use is and how to make the changes that's necessary. Next slide. So we wanted to show this video that has to do with a workflow in your clinic.
Hi,
Good morning. How may I help you?
I'm Alex. I'm here to see Dr. Winkle.
I see you have an appointment today. As I check you in, will you fill out a form? It's called an annual screen. It's just a few questions we ask our patients once a year.
Sure.
Thank you.
The annual or brief screen is given to all adult primary care patients once per year. Patients who score positive qualify for a full screen.
Alex? Hi, I'm Latanya. How are you?
Good, thanks.
Good. I can take that yellow folder from you, and I'll take you back to your room.
Okay.
Alex, you can take a seat on the exam table.
Okay.
The medical assistant quickly scans the brief screen and gives a full screen to patients who score positive.
Okay, I'm going to have you fill out this additional form. You can make sure that you give it to Dr. Winkle when he comes in to see you, okay?
Okay.
Thank you.
The full screen measures severity of substance use to indicate if a brief intervention or referral to treatment is needed.
Alex.
Oh, hi, Dr. Winkle.
Hi, good to see you again.
Yeah, you too.
So you're here today for the diabetes follow-up, right?
Yeah.
Great. And I also see you filled out one of our alcohol screening forms.
Yeah.
Do you mind if I take a look at that?
Oh, sure.
Great. Okay, here. So
Answers on the full screen are totaled and a zone of use is circled at the bottom.
Okay, so Alex, when we add up your score, it looks like you score into zone 2. And zone 2 is what we call the risky zone of use. And it's called risky because even if you're not dealing with any health consequences now because of your drinking, there's good evidence that shows over the long term you're likely to. Okay. Things like
The clinician performs a brief intervention and documents the brief intervention in the progress note.
Thanks. All right, take care, Alex.
After the visit, the clinician drops off the screening form. Later, results from the screening form are entered into the electronic medical record. Under the medical home model of primary care, the receptionist, medical assistant, and clinician all carry out the SBIRT clinic workflow.
Yeah, so you can see the different, how that flow actually worked in a primary care clinic and who all can provide, includes all primary care providers, APPs, behavioral health provider, medical assistants, physician's assistants, front desk staff. So lots of people can be involved in helping out with the SBIRT process. Next slide. One of the big things about substance use, oftentimes we'll have an idea that if people either are not using or have an addiction. And so one of the great things about SBIRT is that it's part of prevention as well as helping people before they need to go to a substance use treatment facility. So when you're thinking about SBIRT and assessing people for substance or alcohol use, we're wanting to think about a continuum, and that at one end might be somebody with a substance use disorder, and then at the other end that we would probably all like to be at is a very positive physical, social, mental health where we're thriving. So what we want to do is to try to help people to get to the thriving side and away from the substance use disorder. So think about it as a continuum. Next slide. And this is a great picture. The traditional model, we either thought people were maybe using responsibly or they were addicted. The SBIRT model, you can see shows a trend from abstinence to experimental use to social use, to then getting into risky levels, or the purple, or 25% of the population may be in the risky category where there's binge use or harmful use. And then in the top 4% may have substance use disorder. Next slide. Now, an important thing to notice that if you're a clinician who is giving diagnosis, that the SBIRT screen is not diagnosing, but to put a diagnosis on the chart, the substances are categorized by, say, alcohol use disorder, opioid use disorder, benzodiazepine use disorder, the name of the substance. And then there's categories of symptoms that are in these impaired control, where somebody may use more of it than is intended or want to cut down. There's social problems, neglecting responsibilities or giving up activities that they used to care about before they were using their substances, or there's risky use, continuing to use despite negative consequences, or physical dependence. So someone does not need to be physically dependent to have a use disorder. And you can see it's not either all or none, but having 2 to 3 symptoms means somebody may have a mild alcohol use disorder or opiate use disorder. Moderate, it would be if they have 4 to 5 symptoms, and severe if there's 6 or more. So there would be more to talk about in terms of making these diagnoses if you are a clinician. But the SBIRT is the first step, and it's talking about screening and getting into the next level of conversation before you're making a diagnosis. Next slide.
Thank you, Dr. Gibson. And I think that's such an important piece, right? That through SBIRT, we are screening, and we are using this as a public health, a population health, public health model to identify drinking and talk about some of the hazards of drinking versus make a diagnosis. So what is risky alcohol use? And I think that this slide is a good illustration of what constitutes as an alcoholic drink or beverage. I know sometimes if I was not doing this work, and my perception of what a glass of wine or what a drink is may be different than the actual picture here. But this picture gives us a great idea of what an alcoholic beverage is. They consider a 12-ounce beer or can of beer, one alcoholic beverage, a 5-ounce glass of wine. Of course, probably the majority of people, when we're drinking wine, we may have a bottle and we're pouring the bottle into the glass. So it's important to think about 5 ounces is what is considered a glass of wine, and then 1.5 ounces of liquor, whiskey, something that can fit in a shot glass is what's considered alcohol. But I want to talk for a minute about what exactly is risky alcohol use, because we see a lot of advertisements, and alcohol is a big part of our society and getting together socially. So we just wanted to talk about, when do we get to zones that are considered risky and or hazardous? And so for men, the limits for men are not drinking more than 4 drinks on any day. And so that's important to think about. If you're drinking a can of beer, that would be 4 cans of beer. For women, that would be 3. If you're thinking about per week, you can see 14 drinks or more for men, we start to be concerned. And for women, that's 7 drinks per week. And so if you had 1 drink per day, that would be starting to meet this criteria. So SAMHSA also talks about binge drinking. And what is binge drinking? And I think it's important that we talk about this, because this can mean something differently for everyone, and everyone might have their own unique tolerance. And so SAMHSA is defining binge drinking as 5 or more alcoholic drinks for males and 4 or more alcoholic drinks for females on the same occasion. And that means, within a few hours. So that's something for us to think about. They also define heavy alcohol use as binge drinking on 5 or more days in the past month. So this starts to get a little technical, which is why we have a calendar here, but just something for us to think about. This is how SAMHSA has identified guidelines, and these are the guidelines for the primary care providers as they're starting to screen for alcohol use. Next slide. So what is risky use? We talked about risky use, and then we talked about binge drinking, but I think it's important that, again, we reiterate, if men consume more than 4 drinks and women consume more than 3 drinks in a single occasion, that is an at-risk level. Any drug use for non-medical purposes would be considered risky. So it's important for us to point out if at some point a patient was taking a medication, even if it was a prescription medication, but that medication is not prescribed to them, that is considered risky use. And I think it's important for us to talk a little bit about what are recreational drugs and what falls into this category. So for recreational drugs, we consider this an expert can be used for tobacco. That's important for us to note. Alcohol, cannabinoids, opioids, stimulants, club drugs, dissociative drugs, hallucinogens, and prescription medication. Any questions about that? I know that's covering a lot of different substances. And please don't be shy. Ask questions in the chat or just shout out your thoughts. All right. You know, I'm just gonna say this. As you know, I reflect in my time working in primary care, a lot of times people are not thinking of alcohol as a drug. They may not be thinking of tobacco as a drug. You know, marijuana may be something that some people are not considering. So it's really important for us to take this as an opportunity to provide education, especially on a public health level. Looks like we did have one comment in the chat. No, just some, okay, we've got some, thank you for putting your name and email in the chat. And this is just a quick reminder, in order to get CEUs, we need to have your email so we could send you the evaluation. But we'll move on from talking about recreational drugs. Next slide. Okay. So what is substance use disorder? As you could see, we have a formal definition, which is at the top of this slide. And I'm not going to go through all of this, but I think it's important for us to know that someone struggling with substance use disorder will have an intense focus on using a certain substance, to the point where the person's ability to function in their day-to-day life becomes impaired. And so people may not be able to go to work. They may not be able to perform their day-to-day responsibilities because they're either impaired by the substance use or the substance, or they are seeking out that specific substance. Okay. It can cause clinically significant impairment, including health problems, disability, and failure to meet major responsibilities at work, school, or home, as we just discussed. Next slide. One of the things that we hear that's important is when we're screening for substances, we hear sometimes that people might self-medicate. And so people may be struggling with some type of mental health issue and use substances to cope with those specific stressors and that specific mental health issue. We know, we see that nearly 1 in 5 adults has had a mental illness in the past year. And of those, 1 in 12 adults, US adults, has had a substance abuse in the past year. So just important to note, sometimes when we're struggling with substances, there's an underlying factor, and we may be using those substances to mask mental health stressors. Next slide. Screening. Jenny was trying to trick me. All right, screening. No worries, Jenny. So we're going to talk a little bit about screening and the importance of screening. It's important to remember, as Dr. Gibson has mentioned, screening is not a diagnosis. So all we are doing with these screeners is gathering information, but we are not making a diagnosis. Next slide. Screening does not rule out a no risk or low risk people. This is information. It doesn't give us insight into areas where substance use is problematic, or does. And it helps us identify patients who are most likely in need for the higher level of care. Next slide. So before screening, it's important to ask permission to ask, could we ask you some personal questions about alcohol and drugs? And let them know I ask all of my patients these questions. Let them know this is going to be confidential, and these questions are going to help provide me the best possible care. It's also important to let patients know that they do not have to answer these questions if they don't feel comfortable, but this will help you provide them the best care. Next slide. This is a public health model, and in public health, we do screen routinely. It's important to know that we're screening for several medical problems, including cancer, diabetes, hypertension, tuberculosis, vitamin deficiencies, and renal functions. And we should also be screening for substance use. Next slide. There are two levels of screening. Universal and targeted screenings. And universal screening is providing screenings to all patients, even patients that are at low or no risk. And targeted screening, we're looking at specific areas that we're going to screen patients for and provide patients who score positive on the universal screen additional assessment. Now I'm going to hand it over to Dr. Gibson for this last portion of our presentation.
Next slide. Yeah, so you'll see that both alcohol and drugs have a single item question. You can have a form that has both of these single questions. And for alcohol, it's called the audit C. And if it's positive, then you go to use one of the longer screens called as listed here. Next slide. So this shows that the single question you can ask a patient is, do you sometimes drink beer, wine, or other alcoholic beverages? If they say no, then you're done. If they say yes, then you ask how many times in the past year have you had 5 or 4 more drinks in one day. So if they say 1 or more times that they've had 5 or more or 4 or more, then you proceed with the full audit. Next slide. And the audit has 10 questions, and it is very brief. It can be administered as a questionnaire on paper or on an iPad or computer, or they can be asked by interview. Next slide. And these are the audit questions where you go into, once they've said yes, then you go to ask them, how often do you have a drink? How many drinks, 0 to 1, and these are scored on the form. How often do they have 5 or more drinks on occasion? And then these 4 through 8 are questions that relate with the DSM criteria. How often have you found that you were not able to stop drinking when you started, failed to do what was normally expected of you because of drinking, needed a first drink in the morning to get going, had a feeling of guilt or remorse after drinking, or haven't been able to remember what happened the night before. The next one is, have you or someone else been injured because of your drinking? And the last one is, has anyone else been concerned about your drinking? Next slide. And then these are scored, and you can get a form that has these where you would score. You saw on the video where the doctor quickly was able to glance down and see what the answers were. And so depending on what category, if someone needs referral or if they are just at risk, or if they have harmful. So based on the score, then your brief intervention would be tailored to that. Next slide. And with drugs, similar, there's a single question drug question. And then if it's positive, then you go on to a longer questionnaire. Next slide. So the single item drug question is, how many times in the past year have you used an illegal drug or a prescription medication for non-medical reasons? How many times? So if they say never, it's over. If they say more than one, then you go to the next screening questionnaire. Next slide. And the advantages, the DAS-10 is a very brief and inexpensive. It's available for the public. It can be given to adolescents or adults. It gives a quantitative score, just like with the audit. Now, the thing about it, like any kind of screen, people can not tell you the truth. So you just have to use your judgment on that. Next slide. Now, these are the DAS-10 questions. And like I said, you can get a form that has these on here. Have you used drugs other than those required for medical reasons? Do you abuse more than one drug at a time? Are you able to stop using drugs when you want to? Have you ever had blackouts? Do you ever feel bad or guilty? Does your spouse or anyone complain? Have you neglected your family? Have you engaged in illegal activities? Have you ever experienced withdrawal? And do you have a medical problem related to your drug use? Next slide. And then this is scored very similarly to the audit, where you're getting low, moderate, substantial, and can guide you. And there's very specific guidelines as to what your intervention can be in primary care, just like in the previous video we saw. Next slide. And these are some very specific screening tools for adolescents and teens that the questions are a little bit changed to be specific for them. Next slide. And this is our final video, and you will see the doctor talking with this young lady. She's about her screen, and you will be able to see a brief intervention in primary care.
Natasha is a 16-year-old student who completed a physical checkup at her school-based health center. After the exam, the nurse addressed Natasha's answers on the CRAFT screening tool.
Is it okay if we go over the form you had filled out? We give this out to everybody who comes in.
All right, so here it looks like you wrote that you drank alcohol on a few occasions in the last year, and you had used marijuana more often 30 days in the last year?
Something like that.
Okay. When students and I talk about their substance use, the first thing I always say, I don't like to tell anyone what to do. That's not my job. Instead, I like to see if there's anything they would like to do, if anything, about their use. So what can you tell me about your marijuana use?
I vape. I have a pen, but I don't smoke it though.
Okay. How often?
A few times a month.
Do you vape anything else besides marijuana?
I did a peppermint oil one. Someone shared it with me.
Okay. Is it okay if I share some information with you?
We know marijuana has effects on the developing brain. For example, it can make it harder for you to concentrate. It can make it harder for you to remember things. And vaping can seriously hurt your lungs. About 1 in 6 people who begin using marijuana as a teenager later on become addicted. So what do you think about all this information that I've shared?
Well, I don't think it's going to hurt me.
How do you think it affects you?
I don't know. It makes me relax, and it's fun to laugh with my friend.
Is there anything about marijuana that worries you? Any things that you don't like?
Well, I don't want to get in trouble like at school.
How could you get in trouble at school?
Well, I can get suspended and I would get kicked off the team, the basketball team.
So staying in school and playing on the basketball team is important to you.
Right.
So when you think about these things, are there any things you would like to change about your marijuana use?
Well, I was thinking to not use when basketball season starts.
What would be the benefits of that?
Well, I play better when I'm not high.
And marijuana affects how well you play. What would be the other benefits for you?
Well, I wouldn't get caught with using a pen, so I wouldn't get kicked off the basketball team.
Okay. So it sounds like you have a goal of not using marijuana once basketball starts. How long do you think you could not use?
For about a month.
Okay. If I asked you to pick a number 0 through 10, 0 meaning you're not very confident at all in meeting your goal, or 10 meaning you're very confident, what number would you pick?
7.
A 7? Why do you think you picked that instead of a lower number like 5?
Well, I'm pretty sure I can stop using for a month and want to play well.
So what steps could you take to help you stop using for a month?
I don't know.
How about this question? What might happen within a month that might make you want to vape?
Well, if I'm stressed or unhappy, that's when I usually want to vape.
What else could you do instead of vaping when you feel that way?
I like to play video games.
Anything else?
I can play basketball with my friend Sarah.
Playing basketball and playing video games are a way to feel better.
Yeah.
Well, I'm glad to hear that you have a goal of quitting for a month and you are confident of reaching that goal. If you're willing to come back in a month or so, I would be curious to hear how your plan works out. Well, good luck with basketball practice. If you want anything or need to talk about something before our next appointment, I'm here Monday through Thursday, and it's always good to see you.
Next slide. Well, unfortunately, we're just about out of time, but we wanted to be sure to, that video does a good job of showing brief intervention with an adolescent. And so we will be doing another expert webinar like this one that will go into more details about the specifics of brief interventions with people who are ready to quit, people who are ready to cut back, or maybe people who are not interested in making changes. So we'll be going over those techniques. And also we'll probably do some about harm reduction with alcohol use. But we wanted to be sure that you have some resources as you do screens, that you've got some resources in Arkansas, and we've got some links. And some of these links are actually links, they will have links on the page to substance abuse treatment centers around Arkansas, as well as I definitely want to point out the peer recovery specialist link, because that's a great resource if you've got somebody that is needing some help. And also has the UAMS AR Connect Now resources, and a page on that has a lot of the facilities around the state. The other thing is I put a link in the chat to Espert, Oregon. And these videos that we've showed are on that website, and it's got everything from workflows to the screening forms that we've talked about, to some handouts that you can be useful, and as well as billing, because that's a big thing that in your clinics you can bill for doing these type of screens. And Kim has talked about other resources to find substance use resources in your area would be using 211 or the Find Help online app. So we appreciate y'all joining us today. It seems like there's not enough time to go over everything that we want to talk about, but the main thing is we want to make sure that you're aware of SBIRT, that it is evidence-based. It is recommended as a standard of care in primary care, and it is effective, and it gives you a way to talk to your patients about alcohol and drug use. And this isn't just about alcohol and drug use, it's about your overall helping your patients being better and their chronic disease improving, and you trying to accomplish your goals as primary care clinicians, and that you can help people in your clinic, and then to get them to the resources that they might need. Thank y'all for coming today. And Kim, I don't know if you wanted to say anything else in closing.
No, it is, we know it's 12:57 and we want to be respectful of everyone's time. As Dr. Gibson said, we are going to continue this training, and we're going to talk a little bit more about brief interventions next time, as well as the fantastic harm reduction materials that Dr. Gibson found and you will not want to miss. And so we thank you for your time and attention today, and we look forward to seeing you next time.